Hey now, I'm Jack Cush, executive editor of RheumNow.com. It's the 10th of March 2017, and this is the RheumNow Week in Review. This week, highlights from the news include a CDC report saying that up to a quarter of Americans have doctor-diagnosed arthritis. A report and review on anterior uveitis showing that monoclonal antibody-based therapy that targets TNF inhibitors can help prevent uveitis. And lastly, a nice review of pregnancy complications seen with lupus will be discussed. But at the top of the news, we actually have a report from an inflammatory bowel disease population that looked at nearly 4,500 patients who were taking TNF inhibitors, specifically looking at whether or not there was an increased risk for demyelinating diseases like multiple sclerosis and optic neuritis. They found, in fact, a twofold increased risk in their cohort compared to those not on TNF inhibitors, the absolute risk being still quite rare at 3.9 per 10,000 patient years. Again, this is a very rare complication. Good to see it in other disorders. Know that it's certainly even less common than drug-induced lupus, but should be considered as a potential side effect when patients are having neurologic symptoms. The American Heart Journal has an interesting report of nearly 2,800 patients who were diagnosed with acute coronary syndrome and looked at whether or not uric acid levels actually had some impact on future risk of cardiovascular events. In fact, it showed that increasing levels of uric acid did significantly increase the risk of cardiovascular events. Most interesting to me was the fact that this was regardless of whether the patient had gout or not, suggesting that hyperuricemia itself may be a significant risk factor for cardiovascular disease. You know, this was actually suggested for a number of other manifestations, including hypertension and renal disease, but it is, I think, quizzical data suggesting, again, hyperuricemia is not that benign even when it's asymptomatic. IgG4-related skin disease is a new phenomenon being increasingly diagnosed. The American Journal of Dermatology has a nice review of the dermatologic manifestations of the IgG4-related syndrome, including red itchy plaques, subcutaneous nodules or papules, psoriasis-like lesions, palpable purpura, and urticarial vasculitis. These have all been seen with that syndrome. Biopsies do show lots of lymphoplasmacytic infiltrates with cells that are IgG4 positive. A nice review of the dermatologic manifestations. Analysis of the FDA adverse event reporting system shows that TNF inhibitors and their injection site reactions are actually less common in patients over the age of 70. I don't know if I've ever noticed this phenomenon. I don't know how many patients you have over the age of 70, but nonetheless, they may have less injection site reactions. And they also showed that patients who are on methotrexate plus the TNF inhibitor were less likely to have injection site reactions. This has been seen in a few reports in the past, something you might want to look for. A nice report sort of furthers our understanding of ANCA-associated vasculitis. As you know, there is some data out there in animal models where ANCA positivity itself is not pathogenic, but you know, ANCA antibodies in an animal where you prime the endothelium with interleukin-1 is more likely to produce vasculitis. Well, this particular report looked at almost 200 patients and showed that ANCA-associated patients who were nasal carriers of Staph aureus were more likely to have relapses than those who are non-carriers, to the tune of 15% versus 2%. That's a significant 7+-fold increased risk. Again, suggesting that there's a curious mix between the presence of the antibodies, but also maybe infection and what that does to the endothelium and activation of other cytokines locally. This week is the AAD conference going on, I believe, in Florida. There's a few interesting reports from there. There's one report that shows that Taltz, or ixekizumab, was superior to Stelara, which is ustekinumab, in patients with plaque psoriasis only. They looked at the usual outcome measures, but looking at just at the PASI 100 scores, those on ixekizumab had a response rate of 49% versus the 23% seen in those on ustekinumab. I think a significant result that was seen. I like to watch this data. Again, this is a new field with the IL-17 inhibitors, the IL-12 and 23 inhibitors, and trying to figure out where they fit in our management, at least of skin disease in our patients, is going to be important. The AAD also has a report on 461 patients with plaque psoriasis who were treated in the SIMPASI trials, the SIMPASI 1 and 2 trials, that showed that, again, doses of 400 milligrams were superior to 200 milligrams in patients taking Cimzia. So this was a Cimzia trial looking at PASI 75 outcomes, about 70–80% at 400 milligrams Q2 weeks and about 60–80% at 200 milligrams. Again, the placebo rates were very low, about 10% or less. There's a nice review looking at what happens when patients are going to discontinue their biologics and don't have restarts, and it clearly shows what's been suggested, what's in the guidelines currently, is that there's a high rate of flares, a worsening of physical function scores, and certainly more X-ray damage. A study that was done for I'm not sure what reason examined whether anakinra, the IL-1 inhibitor, would be effective in treating the fatigue of patients with chronic fatigue syndrome. Goofy idea in my book, but nonetheless, this was done and compared to placebo, and it was shown, in fact, that placebo did really quite well compared to anakinra. 22% reduction, improvement in fatigue versus only 8% on anakinra, suggesting that IL-1 is obviously not a mediator of fatigue in those patients who have chronic fatigue syndrome. A CDC review of the data shows that women infected with the Zika virus are more than 20-fold higher risk of developing fetal malformations. Of course, highest on that list would be microencephaly. The Journal of Bone and Mineral Metabolism looked at an interesting cohort of over 8,000 patients who did not have a previous history of osteoporosis. These are women who went on to have hip fracture, and it showed that despite the fact that they had a hip fracture and were the right age, that only 17% of them actually had DEXA scanning after the fracture, and only 20, and that was within 6 months. Only 23% either were screened or scanned within 1 year, suggesting that even though there's a big red flag of a new fracture in a woman that is at risk, patients are not being screened for osteoporosis, and that's something that we need to teach. The CDC has actually, again, issued this very important report in this week's journal, MMWR, and the website, saying that there's 22.7% of Americans, or 54.4 million adults, who have doctor-diagnosed arthritis. Nearly half of those have actually experienced activity limitations due to their arthritis. They also show that for those who have diabetes and heart disease, there's a twofold increased risk in arthritis in those people, whereas only a 1/3 increased risk for those who have obesity. The point being that if you have comorbidities, you're more likely to have arthritis. A good public health sort of tidbit, but is really an impetus for us to go out and start new policies and planning so we can reduce these rates. As you know, this week we published the results of our January survey about methotrexate and folic acid use, with some very interesting results. You can go to the website and actually download 3 slides on this, or you can read the article about this. One of the interesting and I think somewhat controversial findings was U.S. rheumatologists are pretty uniform in how they use folic acid, 1 milligram per day, with very, very few using higher doses or skipping the dose on the day of methotrexate or using leucovorin. On the other hand, our ex-US, or mostly EU colleagues, rheumatologists, use a different dosing regimen. They tend to use 5 to 10 milligrams once a week. And the numbers here are staggering. 90% of US rheums do 1 milligram a day, whereas 76% of non-US rheumatologists are using once a week 5 to 10 milligrams. What's the deal with that? Joel Kremer writes about that on the website and says, although it seems more physiologic to use 1 milligram a day, you can't argue with the success that the Europeans are seeing either. So nonetheless, I think more research is needed in this area. TNF inhibitor and anterior uveitis, we know from mainly the retrospective analyses of the registration trials that patients who are taking the monoclonal antibodies adalimumab and infliximab were less likely to have recurrence of uveitis. A Swedish database actually looked at their cohort of more than 1,400 ankylosing spondylitis patients followed from I believe 2003 to 2010, and showed that there was a substantial reduction in uveitis events, and those were taking adalimumab and infliximab, but not necessarily with etanercept. In fact, etanercept did not really affect that rate compared to the pre-treatment rates of occurrence. And when you compare etanercept patients were 2 to 4-fold more likely than infliximab or adalimumab to have uveitis events. So again, this is confirmation of a fairly well-known fact, but done in a different way, and I think you can feel good about using TNF inhibitors in patients who may be at risk for uveitis. Lastly, there's a meta-analysis that was done looking at pregnancy complications in patients who have lupus. The takeaway from 11 studies and almost 500,000 plus patients is that C-sections were more likely in lupus. Preeclampsia and hypertension during pregnancy were also more likely in lupus. Spontaneous abortion, thromboembolic disease, postpartum infections were also more likely in lupus. They did show that there was a greater amount of NICU use in children born to lupus patients, and that there was a higher rate of premature birth and infants classified as having a small gestational age at birth amongst those with lupus. Again, these data sort of reinforce the need for better guidelines, which were actually published and presented last week in this same report from EULAR. So you might want to review those EULAR guidelines. I remind you to go out and do the current survey, which is on osteoporosis and what to do with drug stopping. We thus far have almost 200 responses. We certainly would like yours. Go back to your email on Wednesday inviting you to do that. You can go to the website and vote also is another way of doing it, and you can certainly go there and look at the results that are thus far accumulated. That's it for this week at rheumnow.com. You can go to the website and look at the links to find out more information on these particular reports. Be sure to register on the website. We'll see you next week here at rheumnow.com. Take care.